by acknowledging that the land on which we gather is the traditional territory of the Haudenosaunee and Anishinaabe, and within the lands protected by the Dish with One Spoon Wampum Agreement. We are so fortunate this morning to have with us Dr. Esther Chin. Esther is an OB-GYN and assistant clinical professor at McMaster. She completed medical school and residency at McMaster University and holds a master's in global surgical care from UBC. She is the global health lead of the Department of OB-GYN at McMaster. Additionally, she is the principal investigator at UBC's Global Surgery Lab and is also a content consultant, OB-GYN lead, and lecturer for their Essential Surgical Skills curriculum, which is a collaboration with Médecins Sans Frontières, which is currently in its second iteration in South Sudan. She is a member of the SOGC's Rwanda Working Group. Esther recently returned from Angola back in January, where she underwent training in the repair of obstetric fistula. She has previously worked in rural Rwanda, Uganda, Zimbabwe, and Guatemala. Her areas of interest and research are in obstetric fistula, surgical care systems, maternal morbidity and mortality, medical and surgical education, and capacity building. Welcome, Esther.
Thank you so much, Val, and good morning, everyone. It's such a pleasure to be here with you to talk about these issues. So I have no conflicts of interest to disclose. This is a brief outline of what we will be discussing this morning during our time together. So we'll start off by looking at global surgery and where it fits into global health. We'll touch briefly on the landmark paper in global surgery, look at the Millennium and Sustainable Development Goals, and then look at OB-GYN's role in global surgery. And we'll touch very briefly on some contemporary issues in the global surgery discourse. And then the remainder of our time will be spending on obstetric fistula. So the objectives are at the end of this to understand the field of global surgery and how it relates to global health, to understand at least sort of superficially, the broad range of contemporary issues in global surgery, and also the role of OB-GYN in this field. Pertaining to obstetric fistula, the objective is to understand all the complex systems level as well as individual factors that contribute to the development of new fistula, but also that contribute to the persistence of existing fistula. And then understand that fistula really are uniquely positioned as an indicator of a failed surgical system when it comes to OB-GYN. But before we talk about global surgery, let's take a look back at where we came from. So back in the 1800s, the discipline of tropical medicine was developed, and this actually stemmed from colonial medicine. At that time, really, there was no intention of addressing, broad health issues that affected humanity. Really, the aim was to ensure that colonialists would not succumb to various diseases while they were running the colonies, so that they can further the empire's priorities. And so reports from that time, you can see, centered mostly around, plague research. There's a remedy for yellow fever. There's experimentation on human subjects by injecting them with parasites. And then eventually it moved towards more broader issues like this Baby Saving League document from British Guyana. By the 1950s, as many of you know, there were rampant geopolitical changes in the world. And with that, the development of international health. And so at this point, there was the realization that epidemics were a real threat. And so we needed to control these epidemics between national boundaries. And so that's when the WHO started eradication campaigns on malaria, smallpox, polio. And so over time, this moved to a very vertical model of care. So quite focused on individual diseases, prevention and treatment. A classic example would be HIV/AIDS in the 80s and 90s. And then over time, this sort of broadened beyond epidemic control into more general topics and efforts like that of maternal health. Now, by the early 2000s, there was a shift away from that very vertical model of care. So moving away from a very biomedical model focused on specific diseases, working in silos, towards a more horizontal model of care. And at this point, global health was looking at incorporating cross-cutting themes, looking at the various social, economic, political determinants of health, looking at prevention and treatment of both the individual and the population, And this, of course, was affected by an array of factors. So I don't need to tell this audience, things like pandemics obviously were under consideration, but also drug patents, climate change, urbanization, food security, antibiotic resistance. And global health, of course, would include the traditional health sector disciplines, but also various other disciplines. So things like behavioral science, social sciences, informatics, engineering, economics, policy, media, advocacy, and the like. And the aim of all of these sectors working together, of course, was to achieve health for all, and ultimately to sustainably decrease any inequalities, both within a given country, but also among countries. So global surgery is an area where there's work to improve access to timely, high quality, and affordable surgical care for all. And it's been shown that it's actually an essential component of global health. And really, you can't achieve universal health coverage or UHC without considering global surgery. And this actually was one of the focuses of Atul Gawande's speech at the World Health Assembly in Geneva this past week. And so global surgery refers to all the fields related to surgical care. So of course, OB-GYN and the other surgical specialties, but also anesthesia, intensive care, perioperative care, emerge, rehabilitation, palliative care, midwifery, nursing, allied health, and others. But the thing is, global surgery isn't just about the surgery, and it's not just about the surgeon, nor is it just about the anesthesiologist. It's really about surgical care systems. And the various components, as you can see, of surgical care systems and how they're interconnected, and also the various barriers that interfere with those connections. So of course, the patient is important, but also looking at the facility that's available and how does the patient get to the facility? So is there mountainous terrain? Does the patient need to hike 10 to 12 hours, which is what my patients did in rural Rwanda? Are there maybe roads, but do those dirt roads get washed out when it's rainy season? If there are paved roads, are there high rates of road traffic accidents, which would make traveling to the facility actually more risky than staying at home? Keeping in mind that many of these low and middle income countries or LMICs don't actually have an ambulance system in place. And so when the person actually reaches the facility, who's there? Who's staffing it? Is someone there 24/7? What is their training? Are they surgically capable of various procedures or not? And then when you do get inside the facility, what kind of infrastructure is available? Are there ultrasounds? Is there a blood bank? Are there antibiotics, IVs, and the like? And so these two images on the left were taken at a rural 200-bed nurse-run hospital in Angola. So this is accessible only by Cessna plane. There are no roads in or out. And this particular image is of an ultrasound machine that was available at that hospital. But the nurses didn't know how to use it. And so this particular patient was admitted on the antenatal ward with antepartum hemorrhage at about 20 weeks gestation, completely based on history. And then when we did an ultrasound, we realized, in fact, it was a complete molar pregnancy. And then we later realized that there were actually metastases to the lung and these huge, like 13 to 15 centimeter fecal lutein cysts. And this was the blood bank at that same hospital. So global surgery really took off in about 2015 with the publication of this landmark paper in the Lancet. And this was by the Lancet Commission on Global Surgery, also known as LCOGS. And so this paper showed that 5 billion people around the world lack access to safe and affordable surgical and anesthetic care. If you look at this map here, most of these individuals are focused in the bright red and the dark red regions. Furthermore, LCOGS showed that we need 1.27 million additional surgeons, anesthetists, and obstetricians by 2030 to meet global needs for surgical care. And of course, the highest scale of this is going to be in low and middle income countries. About a third of the world's burden of disease is due to surgical conditions. And all of this is going to cost the world's economy $12.3 trillion between 2015 and 2030. Contrary to popular belief, the data actually shows that the annual deaths due to surgically treatable conditions far outweighs and outnumbers that, like by more than fivefold, the annual deaths caused by HIV/AIDS, malaria, and TB combined. Now, I don't need to tell you about the disparity between high income and low and middle income countries. But the thing is, even within a given LMIC, low and middle income country, there is significant disparity between rural and urban populations. And that's with respect to human infrastructure and equipment resources. So in many low and middle income countries, the vast majority of the population resides rurally. Classic example would be Malawi, where 85% or more of the population lives in a rural area. So for those individuals, this first level or district hospital is going to be their first point of contact and possibly their only point of contact when they require emergency life-saving surgery. And this type of hospital is where I spent about 80% of my time in my global surgery work. And so LCOGs named 3 procedures, the bellwether procedures, which they felt were indicators that should be performed at this first level or district hospital 24/7 in order to ensure that they can deliver essential and emergency surgical care to their population. And these 3 procedures are C-section, emergency laparotomy, and operative treatment of long bone fractures. Now, there are 2 implications to this categorization of bellwether procedures. The first is that if a hospital can perform the bellwether procedures, it's thought then that they can probably handle the majority of surgical emergencies that come to them. So both from a surgical standpoint, anesthetic standpoint, but also meds, infrastructure like electricity and running water, and personnel. And then the second implication here is that procedures that fall outside of this bellwether trio can generally wait. So it can wait for this patient to be transferred or referred to a higher level or different center, or it can wait for a specialist to come visit and undertake the procedure. Now, LCOGs also developed some core indicators to monitor universal access to safe, affordable surgical and anesthetic care. And these are to be interpreted together, because if you take any one of these individually, it really doesn't give you an adequate representation of the care available. However, I'd like to draw your attention to these 2. And the first target that we hope to achieve by 2030 is that more than 80% of the population will be able to access within 2 hours a facility that can undertake the bellwether procedures. And the second indicator to focus on here is that 100% of countries should have more than 20 SAO, so surgeons, anesthetists, and obstetricians per 100,000 population, again, by 2030. So where does OB-GYN fit into all of this? You may recall the Millennium Development Goals, or MDGs, consisting of these 8 targets. Sadly, the world only achieved 3.5 of these targets, but target 5 was really the one that was specific to OB-GYN. And we can see here that, unfortunately, the maternal mortality ratio only fell by 45% instead of the 75% that was the target. And you can see that Southern Asia made better progress than countries in Sub-Saharan Africa with respect to the decrease in MMR. We did see an increase in the number of births attended by skilled birth attendants, increased from 59 to 71%. And about half of patients, pregnant patients, will receive at least 4 antenatal visits, which is the WHO recommendation. In Sub-Saharan Africa, this only increased from 47 to 49%. And then finally, although target 5B was not reached, there was no universal access to reproductive health. By the end of the MDGs, there was increased contraceptive use. There's a lot of text on the slide. It's not for you to read. The red is just to show you, again, all of the MDGs that were not met. And again, you can see here MDG 5 pertaining to our specialty is all red. So in 2015, we entered the era of the Sustainable Development Goals. And right now we're about halfway to the endpoint of 2030, at which point it's hoped that these 17 goals and all of their sub-targets will be reached. Now, of these 17 Sustainable Development Goals, there are 5 that are directly pertinent to OB-GYN, as you can see here. So no poverty, good health and well-being, quality education, gender equality, and reduced inequalities. So back to the question about where OB-GYN fits into global surgery. So if you think back to those 3 bellwether procedures, and coincidentally, the S and O of SAO, OB-GYNs have training in 2 of the 3. And that aside, almost everything we do in OB-GYN is dependent on having various components of the surgical care system, so that Venn diagram, poised at the ready to respond. At any given point, given how dynamic our presentations are, our patient might need the OR, an anesthetic, a blood transfusion. So certainly OB-GYNs need a seat at the global surgery table. Moreover, C-sections are actually the most ubiquitous surgery that's done in low and middle income countries. And we know that C-sections can be both life-saving, but also disability averting, which we'll talk about shortly. So when we look at this particular map, which shows the SAO distribution, we can see that there is gross inequitable distribution of surgeons, anesthetists, and obstetricians worldwide. In the entire world, we have just under 500,000 OBs, 1.1 specialist surgeons. And although low and middle income countries make up just under half of the world's population, they only contain about 19% of surgeons and about 29% of all OBs. When it comes to SAO density, low income countries only have 0.7 SAOs per 100,000. Lower middle income countries have 5.5. Upper middle income countries have 22.6 SAOs, whereas high income countries like ours have almost 57 SAOs per 100,000. Now, of course, this map is only showing you distribution of SAOs and not actually access to care. But if you think back to that red map that I showed you earlier about surgical access, you'll see if you focus on these very pale yellow and pale green areas of the map, they more or less correspond to the bright red or dark red areas of that surgical access map. So certainly there is correlation and association. Now, keeping in mind that most of the world's population, if they're served at all from a surgical care standpoint, are usually served by non-physicians and non-specialists. And that brings us to one of the most highly discussed and debated topics in global surgery, which is task shifting. So task shifting refers to tasks that are moved from a very highly specialized workforce to a less specialized workforce to allow what they call rational redistribution of healthcare workers. Typically, we are shifting to non-specialist physicians, so generalists, typically sort of equivalent to our family physicians here in Canada, or non-physician clinicians. So a prototypic example would be clinical officers in Malawi. So in Malawi, clinical officers have 3 years of post-secondary training, followed by a year of internship, clinical rotating internship, and then after that, they're by themselves at a district or first level hospital in a rural community functioning on their own. And so clinical officers perform more than 90% of the C-sections in Malawi. Another example would be non-physician clinicians in Tanzania who perform inguinal hernias, prostatectomies, and exploratory laparotomies, and also nurse anesthetists who are responsible for all types of anesthesia, local, regional, general anesthesia, and much of sub-Saharan Africa. A non-surgical example of this would be that of HIV or TB care in Haiti. So some of you may have heard of Partners in Health, which was co-founded by the late Paul Farmer. And so back when they started, they came up with this novel idea of community health workers. So basically training up lay people who have no healthcare training whatsoever to become these CHWs, to then implement HIV testing, interpretation, referral, following folks on stable ARVs or TB therapy, and then making regular visits up in the mountains or very rural, remote regions to ensure that they're adherent to their treatment regimen. So this particular theme is going to come up again when we talk about fistula, and you'll see sort of its implications in fistula care. We'll touch on 4 more contemporary issues. And again, each of these would be 1-hour talks in and of themselves. So this is certainly not a comprehensive discussion. Another discussion is that of gender equity in global health and global surgery. And I'll just preface this by saying that currently there's minimal data and minimal studies on non-binary individuals. And so you'll see that much of the data is still with respect to binary gender. So women make up in the data about 70% of health workers globally, but only 25% of senior leadership in this sector. And you can see in this infographic, we're talking about heads of state, global health organizations, deans of public health medical schools, ministers of health, et cetera. Of course, this was exacerbated by the pandemic. There's lots of literature looking at the unequal burden that was placed on women. And of course, in global health work, much of this work that's undertaken by women is either unpaid or under-recognized, including things like being a community health worker. This is a global phenomenon in both high and low and middle income countries, but in particular, folks that are in LMICs bear the brunt of this. Specifically, and this again was one of the main topics at the World Health Assembly in Geneva this past week. They discussed the fact that women from these very marginalized backgrounds are often the most excluded from health leadership. And keeping in mind there's intersectionality here. So we're talking about marginalized from a race standpoint, class, caste, age, ability, ethnicity, sexual orientation, gender identity, and migrant status. And in particular, those from LMICs only hold one leadership position in a multilateral global health organization, and they hold less than 1% of the board seats in nonprofits that promote health and global health agenda and policy. So in OB-GYN, these are, of course, both our colleagues, given the demographics in our discipline, but also our patients. Another issue that's being discussed right now is that of decolonizing global surgery and also global health. In academia, there are lots of barriers to education. So even if someone, say, has done all of their schooling in English, often our colleagues from LMICs are asked to provide proof of language proficiency. Authorship is very high and concentric in the global surgery and also global health world. There are issues around passport privilege. So unfortunately, we saw this at the Bethune Roundtable this past weekend in Toronto, which is a global surgery conference. There were 11 colleagues from Ethiopia that were supposed to attend in person, but ended up not being able to get into Canada because of visa challenges. And then certainly there's the issue of having enough research capacity in an LMIC. And again, there was an elegant poster presentation on this at the Bethune Roundtable, looking at a lot of the barriers to undertaking research in LMICs. From a clinical standpoint, there's a lot to discuss in terms of medical donations and the ethics around that. But also thinking about the fact that usually high-income countries or institutions hold the purse strings. And often then these donors direct the priorities and agendas of various global health and global surgery efforts. And then finally looking at truly having bilateral exchange instead of sort of a unilateral, HIC to LMIC exchange. Another topic that's discussed is that of charitable platforms. So in comparing these three platforms, Schreim and colleagues in this 2015 paper essentially stratified them in this order from sort of best, if you will, to least. So they looked at a surgical specialty hospital, classic example being Hamlin Fistula in Ethiopia, which is of course on the ground in Ethiopia, investing in the infrastructure of that community, employing locals, building up capacity, both in terms of education and infrastructure, and serving the community full time. And that is superior to, say, Mercy ships, who will sail in, completely self-contained though, not using any of the OR resources, not using the personnel or human resources of that particular LMIC. They provide care, but then the issue is they sail out, and then all of the follow-up, complication management, everything like that is being managed by the locals. Furthermore, when you sail in and sail out like that, you're not building capacity locally. You're not improving the education or skill set of the locals. You're not contributing to the infrastructure development, nothing. And then finally, the worst of these three platforms would be the prototypic 1 to 2 week fly-in surgical mission trip and then flying back out. So in those settings, these camps, which is the other term, utilizes usually purely high-income country teams. There's no investment into local capacity. You're potentially displacing regular OR volume and cases. You're taking away their human resources and personnel, say the nurses, porters, cleaning staff, etc. You're using their autoclave, using their sutures, using their drapes, and then you take off. And again, no investment into the infrastructure or the capacity from an education or clinical standpoint. And then finally, the other issue that's being discussed quite a bit now is planetary health. And so this was actually the theme of the Bethune Roundtable this past weekend at Bethune. And really the premise here is that we know that climate change is happening, but climate change disproportionately affects those people that live in LMICs. And in particular, we know that the population we serve is particularly vulnerable socially, economically, culturally, because in these communities, these are the individuals that rely heavily on natural resources for livelihood as subsistence farmers, but also for food security. They're also the ones that are culturally responsible for getting water. So if there's a drought, you're now walking farther or longer to the stream or to the well to fetch water. And then furthermore, when there are natural disasters as a result of climate change, there's usually catastrophic expenditure to deal with the downfall of all these natural disasters. And so this infographic is from the second paper by Zygam, illustrating the various surgical, anesthetic, and OB implications of greenhouse gas emissions. So those of you that know me outside of medicine know that I'm a bit of a gardener. So you'll just humor me for a second here, because this next question does not require you to be a gardener to answer. So you can throw in the chat your answer to this, but looking at this image, which side of the tree is sick, and how do you know? Put in the chat. Like a 99% chance people will get this correct. Nobody's putting it in the chat. The right side. Okay, and why do we think it's the right side? Right, so people are saying it looks really sparse, the leaves, the color. Okay, exactly. So obstetric fistula are very similar to this in that similar to these diseased leaves on the tree, in that their presence is an indicator that there is a much greater problem, either underneath the surface or in the environment. So, as many of you know, fistula are a connection in medicine between any two epithelial eye surfaces. So obstetric fistula are a type of genital fistula. So it's basically a connection or a hole between the urethra, bladder, ureter, rectum, and the vagina or cervix or uterus. So when we say obstetric fistula, most people think immediately of simple vesicovaginal fistula. So all the diagrams I have here, I've indicated the fistula with a blue dot as if we're doing a methylene blue test together. Okay, so this is a simple VVF, so a connection between the bladder and the vagina. So that's a sagittal cross section. Whereas here, again, oftentimes you'll be able to see it. If not, you'll be able to palpate a simple VVF. You'll feel a little divot along the anterior vaginal wall. But sometimes it'll be a little bit harder to see. It'll be tucked in up here in the corner in the vaginal fornice, possibly even tucked in up against the pubic bone. But the thing is that fistula are actually really heterogeneous. They're not all like this. And you'll see that this has implications in training up fistula surgeons. So they can get even more complicated like this one. So when you go in to examine this type of patient, you're basically going to feel left and right, all pubic bone, because there's complete disconnection between the urethra and the bladder here. So this is a circumferential fistula. And then this is a vesicocervical or vesicouterine fistula, so connection between the bladder and the cervix or lower segment of the uterus. And then this is a ureterovaginal fistula. So at the time of C hyst, someone inadvertently cut or tied off the ureter. And so now you have a connection between the ureter and the vagina. The other issue is that, of course, this tied off portion is going to be stenosed. And so you have proximal dilation of the ureter. So we know that when it comes to obstetric fistula, about 90 to 92% of them are caused by or related to childbirth. And the issue usually is obstructed labor, which goes on for like 3 to 5 days, no access to definitive delivery, which is usually C-section for a number of factors or for a number of reasons. And the babies are stillborn in 90 to 95% of cases. And what's happened is that the constant propelling of the baby's head over these 3 to 5 days causes pressure onto the tissues and therefore leads to necrosis and ultimately a fistula. If you ignore the text here on the right, the pink spots just again show you those points of pressure. But how do we get to this point? Like, why is there obstructed labor for 3 to 5 days? And why is there no definitive delivery? So back in 1994, Thaddeus and Main published this article, which illustrated what they call the 3 delays model to try to explain some of the contributing factors leading to maternal mortality. This has since been extrapolated to a number of other things in global surgery, including trauma, but we can apply it to the index labor that leads to obstructed labor and therefore fistula. So the first delay is that of deciding to seek care. So maybe, the abnormal labor progress isn't recognized. Maybe it's attributed to sorcery or infidelity, usually on the woman's part is the thought. Or maybe the permission of a male relative needs to be sought. The grandfather, the uncle, the dad, the second male cousin, the brother, and maybe that person's really far away and can't be reached. But let's say someone does make the decision to seek care, there may still be a delay in reaching the medical facility. As we alluded to earlier, there can be many terrain, geographic, topographic delays. And then let's say someone actually makes it to a facility. There can still be a delay in the facility in getting the appropriate care. Maybe obstructed labor isn't recognized. Maybe it is, but there's no OR capability. Or maybe, there's no power that day. Or maybe there's no one to safely perform a C-section, or there's no anesthetic. So all of these will contribute to that pathophys of obstructed labor. So far we've been talking about obstetric fistula related to obstructed labor, but there are also non-obstructed labor causes. And these are iatrogenic fistula, usually due to C-section where someone inadvertently sutures the bladder to vagina, cervix, uterus, C hyst, some operative vaginal deliveries from vacuum forceps, and sometimes symphysiotomy. But there are also non-obstetric causes. So certainly perihysterectomy, you can have, again, an iatrogenic fistula. It can be secondary to trauma, sexual violence, female genital cutting. One form of female genital cutting, which is a traditional practice, is called gishiri cutting. So this is a form of FGC, which is done among the peoples of the Hausa and Fulani regions of northern Nigeria and southern Niger. And it's done for infertility, dyspareunia, pelvic organ prolapse, UTIs, difficult labor. And so they take a gishiri, which is a long knife that salt traders used to use to cut off blocks of salt, and they run that along the anterior vaginal wall, not surprisingly causing fistula inadvertently. Malignancy in this particular setting, usually advanced cervical cancer, can cause fistula. Radiation, inflammatory conditions, which are more common etiologies in high-income countries, and also infection from TB or lymphogranuloma venereum. But the take home here is that when we talk about obstetric fistula, classically that's referring to obstructed labor, whereas iatrogenic fistula is usually referring to a procedure-related fistula. So again, classically C-section and HIST. So just over 100 years ago, fistula actually existed in North America. This is the Waldorf Astoria Hotel in New York City. And this is the site of the last standing specialized fistula hospital in North America, which closed in 1895 because of decreasing case numbers. And more recently, just under 100 years ago in Asia, obstetric fistula existed. This is a thesis written by Dr. David Lansborough in 1925 on patients in then Formosa, present-day Taiwan, who had vesicovaginal fistula. So all of that is just a reminder that in the world, obstetric fistula have been successfully eradicated with increased access to safe obstetric care. So these days, fistula is typically in sub-Saharan Africa and Asia. The estimates are, there's a bit of a range. The upper limit numbers here are what the WHO quotes, so the 2 million worldwide and 50,000 to 100,000 new cases every year. But the challenge in obtaining accurate estimates is that these patients typically live in very rural and remote areas. So they're hard to reach and they're often in isolation. And so there's usually underreporting or people remain undiagnosed. So to understand how fistula forms, we need to talk about the components of the soil or the environment, if you will. And you'll see that these factors all coalesce to create this setup for obstructed labor, which end up leading to fistula. So the first set of factors lead to a less developed pelvis at the time of labor and delivery. So things like malnutrition, which is tied to poverty, increased school attrition rates for girls, which is also tied to poverty in terms of not being able to afford school fees, but also culturally, there just may not be the norm for girls to attend, higher level school. And that in and of itself, the attrition is tied to a higher probability of child or adolescent marriage, which of course is coupled with just societal norms of marrying when someone is a child or adolescent. And so all of that will increase the risk of a less developed pelvis and therefore increase the risk of obstructed labor. So in between, there is also often no agency, limited access or no access to contraceptives and or no societal acceptance for contraceptives. And so there's usually an earlier age at first conception. And then let's say the person gets pregnant. There's usually limited access to antenatal care, either in terms of barriers or limited acceptance of antenatal care. Which also means then that you can't detect, things like macrosomia or fetal abnormalities like hydrocephalus, which might further increase the risk of obstructed labor. And then intrapartum, we then see again the 3 delays model at play. So the delays to seek care, reach care, and then the delay at the actual health facility, which all then leads to either obstructed labor not being recognized or not promptly diagnosed and treated. And as a result, the fistula forms. So as you can see, although fistula is not inherently life-threatening, patients have told me it's a different type of death. And this is because of a cascade of various social, psychologic, economic consequences that not only interfere with their quality of life, but also can change their entire life trajectory. So because of the fistula, so the connection between vagina and bladder or vagina and rectum, there's of course urinary or fecal incontinence. As a result of the smell, these patients are typically abandoned by their spouses, their family, the community. So essentially they're kicked out of the villages and they live off by themselves in isolation as pariahs. If the spouse was the only breadwinner, then the person might lose economic viability. The other piece here is most of these patients say sell veggies at the market. But now that you're leaking urine or feces, people are going to be less inclined to buy veggies from you at the market. So again, you lose economic viability. So these folks often live in isolation, and they may also suffer from other components of the obstetric fistula injury complex, most commonly foot drop from L5-S1 spinal nerve root damage. So that can make it harder to access care, which is typically in a more urban setting. Furthermore, if you're leaking urine or feces, you're not really going to want to take the bus to get to the urban center to seek care. And other folks just don't even know that there's a possibility of cure, and they think that they're resigned to living with this for life. And so most of these patients spend the majority of their waking hours tending to hygiene matters, washing, cleaning, disposing of soiled items. And some people live like this for up to 30 to 40 years before they actually access definitive care. So with that said, especially as a surgeon, the sort of natural next question would be, well, there's a problem, how do I fix it, right? Especially from the standpoint of the fistula, how do I repair the hole? And up until recently, the actual fistula repair has been the focus of fistula care. But as you can see, the repair in and of itself is really but one piece of the entire spectrum of care. So we do need to talk about holistic care in terms of prevention, trying to decrease the incidence of new cases, good antenatal, good intrapartum care. Post-repair, we need to look at rehabilitation and reintegration, addressing all of those psychosocial issues that have come up, talking about how to reintegrate into the community and or forging a new life on your own. And then finally, looking at advocacy and outreach to address some of those upstream beliefs, attributable causes of fistula, talking about how to promptly recognize obstructed labor, looking at infrastructure changes, policy changes, and the like. But let's focus on fistula repair for a moment. Before I actually talk to you about the surgical repair, we must mention the controversial legacy of J. Marion Sims. So you may know him from his namesake, the Sims retractor. He's also been called the father of modern gynecology. Yeah, he was the former president of the American Medical Association, the former president of the American Gynae Society, and he has been credited with pioneering the techniques that we use to this day to repair obstetric fistula. But the issue is that these techniques were trialed and perfected on enslaved women. Most of these women were anonymous, but three we know the names of: Anarcha, Betsy, and Lucy. Anarcha in particular, it's been documented, endured 30 surgeries over 4 years, all without anesthesia. And in the era of chattel slavery, there was no agency, no consent, only the consent of the owner was required. And so you can see here in this painting by Robert Tom, circa 1952, there's Sims with his arms crossed. This is Lucy. And I know art interpretation is very subjective, but in my opinion, there's significant power imbalance here, subjugation, tension, that's all palpable. So artists like Michelle Browder are trying to reframe the discourse by drawing attention to these women who were enslaved and endured surgical experimentation, partly with sculptures like this, depicting Anarcha, Betsy, and Lucy. And this is termed or entitled the Mothers of Gynecology Monument in Alabama, and it was unveiled in 2021. So when we look at fistula repair, this is a simple VVF. This is what we would call a 1AI in the GO classification. And typically the repair is usually there's good postoperative response, good outcomes. Usually only one repair is required, sometimes two if the first one fails. You can see here that we ended up actually getting a little bit closer to the ureters, and therefore we put in a ureteric stent. In terms of positioning, this is actually one of the most crucial steps. The patient needs to be in the steep Trendelenburg with a very exaggerated lithotomy position so that the surgeon can look directly at the fistula. Otherwise, the ergonomics and just the technical aspect ends up being quite challenging. But the issue is that only 1 in 50 patients actually get a surgical repair, and that's because of a number of factors. So the stigma makes it very hard for these patients to seek care. When you're living in isolation, it makes it very hard to harness social networks for information on your local health resources. So they might think that they're the only person suffering from fistula. Maybe they've now internalized some of those attributable causes like sorcery and whatnot. Maybe they don't know it's curable. And perhaps because you're not connected to your local network, you don't know that now your local hospital has a visiting fistula surgeon or now is offering fistula repairs. Or maybe you don't know that the UNFPA is coming through with a surgical camp. So all of those things contribute. And then the actual care is quite inaccessible. So the issue is that most fistula hospitals are located in urban centers. And since most of these patients are rural and remote, they do have to travel those distances, not to mention now getting on a public bus while leaking urine or feces. The surgeries themselves are very long and complicated, quite heterogeneous. There's actually a very high rate of surgeon attrition because there are competing priorities in these very limited resource healthcare systems. And then on top of that, unlike say C-section, where there's a huge pool of high income surgeons who can go and help to build capacity and train up the next generation of providers, there really is not that same high income pool of skill because we don't have obstetric fistula here. And even the ones that we do have, the etiologies are very different. And so when you have obstructed labor, the fistula that results has what we call this field of ischemia. So even where there isn't a hole, the tissue is very abnormal and the planes are basically non-existent. And so it becomes a very technically challenging and different surgery. So just to further illustrate the heterogeneity of fistula, this is a very large vesicovaginal fistula. It's about 4 centimeters in diameter. And right now you're looking straight into the bladder. The ureters are right here on the edge. So you can imagine this is a very technically challenging repair. Some patients unfortunately require these more advanced procedures. So a ureterosigmoidostomy procedure like the Mainz 2 pouch. So this is where you essentially implant the ureters into the rectosigmoid. But this is very resource intensive and not every center can offer this. So you have to assess the patient pre-op for anal continence to liquids. You have to have good patient selection, usually an older patient because there's a risk of colon cancer as time goes on. You need to do ongoing electrolyte monitoring because of absorption issues. So again, not really amenable to all centers and takes a lot of training to do this type of procedure. Some patients need vaginal reconstruction with flaps. So this is a Singapore flap, which is a pedicle pudendal fasciocutaneous flap. So this would be, say, for someone who has significant vaginal stenosis or really distorted anatomy, sometimes just from the actual injury, sometimes from multiple repairs. So you can imagine that these types of procedures take a long time to learn and to develop expertise in. And furthermore, folks with this level of skill are typically in urban centers, which brings us back to those barriers that I showed you on the previous slide. So let's go back to the spectrum of fistula care to look at some unmet needs. So when we look at the antenatal and intrapartum care, namely C-section, we think about how prior to global surgery becoming a field, the opponents would claim that surgery is really expensive, it's a luxury, it's not cost effective. But in fact, some health economists have done these very elegant studies to show that emergency C-sections are among one of the most cost-effective interventions, and actually more cost-effective than some more common public health measures. You can see here that an emergency C-section costs anywhere from $15 to $380 per DALY, so that's a disability-adjusted life year averted, compared to say ARVs, which are $900, or oral rehydration, which is more than $1,000. So we know that then increasing access to C-section will, of course, help to decrease the incidence of new cases, but also will overall achieve better health for this population, therefore helping us to achieve those sustainable development goals. But the issue is that you can't just increase quantity of C-sections. You also need to talk about quality. And so in countries like Ethiopia, where they have made huge strides in increasing access to comprehensive emergency obstetric care, or CMOC, we're actually seeing a shift in the etiologies of fistula. So we're actually shifting away from the classic obstructed labor towards a greater proportion of iatrogenic fistula. And so again, the thought is that somebody at C-section has inadvertently sutured bladder to uterus, vagina, cervix. And so this will likely need to be addressed by capacity building training for generalists at that first or district level hospital who are undertaking the majority of these C-sections. And in fact, some of the people on this call are working with me. We're doing a study to map out the knowledge pertaining to iatrogenic fistula. When it comes to the actual repair, the unmet need is that of fistula surgeons. So I had alluded to earlier that these procedures are very heterogeneous, they're poorly remunerated, they're long, they're complicated, there are other competing priorities. In these settings, there's often low staff morale, electricity kind of, splits in and out all the time. The working conditions aren't great. There aren't the supplies or infrastructure you need. Often for fistula repairs, you want that UR6 needle, which we take for granted here. But if you don't have a UR6 needle, it makes it really hard to navigate those corners. And so those repairs are much more frustrating. And up until now, we actually didn't really know what was needed when it came to training and capacity building. We didn't know, how long it would take or how many cases someone would need to acquire competency in repairing fistula. So I'm very pleased to let you know that our scoping review has been accepted for publication, where we summarize all of this and we look at how many cases, how long it takes to train up a fistula surgeon. Although unfortunately, there's still no stratification of this data based on the trainee's own clinical background. And then when it comes to the rehabilitation and reintegration piece, the unmet need is actually not in the specialized fistula care hospital. So this is from Hamlin Fistula in Ethiopia, which has a lot of resources, has this wonderful rehab reintegration program where they have physiotherapy. Often these patients have proximal muscle atrophy and wasting because they've been lying in bed leaking. So they require a lot of physio. There's literacy skills training, entrepreneurial mentorship, social support, psychosocial supports as well. The unmet need really is in the general hospitals. So this is an image from CML Hospital in Angola where I have been working. And so the issue is that in these general hospitals, fistula is but one of a slate of competing priorities and procedures. So general surgery, thoracics, vascular, ortho, trauma, ped surge, ENT, gynae, all of those procedures are done by 2 to 3 surgeons. So you can imagine then, there are no resources and there's certainly no personnel to dedicate towards these comprehensive rehab and reintegration programs to provide this holistic care for patients. Another issue is actually that of the rehab and reintegration for patients that are deemed to have inoperable fistula. And this might be because there've been many attempts, maybe the anatomy is really distorted and they can't find tissue planes in that field of ischemia. Because of course the rehab and reintegration for that discussion for that type of patient is going to look very different than the other patients. And finally, when it comes to advocacy and outreach, the unmet need is really that this is very resource intensive and very infrastructure dependent. So you need a local champion and you also need local buy-in to do this. One of the success stories has been around community health workers like Rashid in Uganda. And so community health workers are lay people with no healthcare training, and they know the local language and the customs and the belief systems. And so Rashid has done a lot of community sensitization on various OB topics, on fistula prevention and treatment and birth preparedness. They've also had very great success with sort of innovative technology usage or telecommunications usage. So with Fistula Care Plus in Malawi, they developed this hotline where patients could discreetly call in. And there are a bunch of screening questions and you kind of enter your answers based on using a touchtone phone based on those screening questions. And depending on your score, you'll then get transferred to a community health worker who will then set up a referral and also come and meet you and give you a transportation voucher for you and a +1 so that you can go to this, more urban fistula care hospital to get assessed plus or minus treated. Former fistula patients like Margaret and Fiona have also done tremendous work, and they're probably among the strongest and most compelling advocates. They've been able to change attitudes in their communities around fistula, educate on the attributable causes, so not infidelity, not sorcery, and they've been able to convey that fistula is curable since they're walking examples of this. And then finally, they've also worked at higher policy levels, like with the UN, UNFPA, to try to change policy pertaining to fistula. And then finally, the Hamlin Fistula Hospital not only has offered care and rehabilitation, but they've also created a midwifery college. So they're training up these midwives who are expected to return to their communities to address stigma and to change misconceptions. But of course, in providing the antenatal and intrapartum care, we're kind of going back upstream to try to tie it back into decreasing the new cases. And then finally, research, of course, underpins all of this. Research is what helps us to identify those gaps in care and the unmet need. It helps us to monitor and evaluate the effect of existing programs and projects. And it also helps us to recalibrate our efforts, right? So for example, with that changing paradigm in Ethiopia from obstructed labor to now iatrogenic fistula etiologies, we can kind of assess that paradigm shift and change our interventions accordingly. So as we've seen, bringing it back to the tree, fistula are like the leaves on the tree, right? It's not really just about the leaves, and it's not enough to just repair the fistula. We need to look at the root causes that underpin all of this, because again, the fistula are an indicator of the overall health of the surgical care system, and they give us a hint as to some of the issues that exist beneath the surface or in the surrounding environment. So, things like addressing gender equity, nutrition, education, you'll see that many of these are not even directly healthcare related and not in the traditional healthcare sector necessarily. Gender-based violence, antenatal care, SEMOC, accessible, high quality, safe C-section, contraceptive access, and then all of the infrastructure issues that underpin this. So transportation, electrical issues, telecommunications for referral or for reaching patients, water, policy. You can see that by addressing all of these upstream issues and working to implement efforts here, we can affect then the social, psychological, economic, and of course the physical health of this particular patient population. So in terms of how one might be involved, so I should preface this by saying that all of these endeavors need to be in the context of a true partnership, meaning that the agenda, the goals, the needs need to be set by a partnering low and middle income country institution or stakeholder. And so if your LMIC partner requests that your high income country institution or department contribute in these ways, then certainly we can go forth. And so we can work together in things like capacity building, specifically education. So for example, with my work with the UBC Global Surgery Lab, we've created these e-modules for the Essential Surgical Skills curriculum, which is targeting or teaching surgical procedures to non-surgeons. And these are life-saving procedures. So right now, as Val mentioned, this is currently in its second iteration in Obel, South Sudan, and it's going to be tied in with lectures and also skills training labs. And then in 2024, we're hoping to be able to launch it in the Central African Republic en français. And this is a collaboration with Médecins Sans Frontières. And then also thinking about things like sharing grounds links. So making our knowledge completely open access to our partners in LMICs. And then, as some of you know, the St. Joseph's Hospital here in Hamilton does have an international outreach program that has been going on for many years. Most recently, Dr. Mike Kagawa from Makerere University in Uganda was one of the first OB-GYNs to come over for a full year to get extra training in a particular area of interest. So for him, it was ultrasound and MFM. We can also look at building research capacity. So both in terms of mentoring, but also collaborating on projects, availing of our librarian services who, as many of you know who do research, are so central to what we do, but also looking at helping to develop registries. So the research that we do is dependent on collecting good data, and some of the data that we collect needs to be collected in a sort of organized, concerted fashion through registries. So as you may have heard, some folks in our department are working on a confidential inquiry system and obstetrical surveillance system in Guyana. And then on that note, looking at helping to secure funding. So I know in medicine, we don't like to talk about money, but the thing is, in these types of efforts, funding is quite crucial. And when it comes to funding, we need to ensure that our monetary and other resources are primarily devoted to on-the-ground efforts and not to fly high-income folk back and forth, right? The actual outputs need to be in country. So some of you may know that our Global Health Committee is working on a Global Affairs Canada grant to support the development of obstetrical surveillance systems in other LMICs, aside from Guyana. And we're also looking at applying for a Royal College grant to support an MFM fellowship at Makerere University. And then, of course, if your LMIC partner requests it, you can also, endeavor to help in more tangible ways. So, for example, sourcing needed equipment. In our specialty, the natural first piece of equipment that we would think of would be ultrasound. But you may need to advocate for an older model or a lower cost model so that you can easily access replacement parts, so that the maintenance and troubleshooting is a little bit more user-friendly, so that it has long-term applicability in the LMIC setting. And we just need to be very cautious with medical donations. And I have a whole other talk on that, but there's lots of ethics around medical donations from high-income countries. And then finally, if requested, certainly we can think about sending faculty with applicable expertise, again, with the focus to teach and to help support research with service delivery, so the actual clinical service part playing a backseat role. And that is all I have for you this morning. Thank you for your attention. Obrigada.
Thank you so much, Esther, for a really complex topic squeezed into 55 minutes. Amazing, amazing job. We have a few minutes. I'll just stop talking and open up to questions or comments. Dr. Barrett.
Well, all I can say is, wow. We've met, and how long did we make contact, Esther? Like, I don't know, about 6 months ago, or maybe a year ago, and you're leading our new Global Health Committee, and it's just so impressive. We're so lucky to have you here. There's huge opportunity in our Global Health. The committee meets, I think it's every month or 2 months. It's and maybe we need to meet more. The meetings are full. There's just no end to opportunity. There's so much happening on for residents. There's going to be an opportunity for you to spend 4 weeks partnered up on a faculty coming up in Guyana. You mentioned You mentioned the surgical program. There's just so much going on, and there's opportunity for people to join this Global Health Committee if anyone's interested to call you. Obviously, we're following on the footsteps of giants. There's only one Gene Chamberlain who sort of paved the way for us, and we're taking this together. But global health is our health, really. I think you made that really clear, and this is going to be a huge opportunity. And multidisciplinary Shasta wants to come on. This is going to be a major thrust of our department going forward at all levels, because we can make a huge impact like I don't think anybody else can. And Esther, you're at the forefront with this energy, expertise. Really, thank you for that. I don't know if there's any questions, but really, as you can hear, the sky's the limit with this. So thank you for that. I'm getting lots of texts. I'm getting email. Wow. So you guys, you're just seeing what I saw, and I didn't do anything. He said, Esther, will you come and help us? And all of a sudden we have this new global health sort of focus, which was always there, I guess, but just needed someone to pull it together, which is what Esther's doing. And so Esther, thank you. We're gonna do amazing stuff together. So everybody, you don't have to email me. You can email Esther directly. She's got this. This is a major focus for our department. Residents, please get involved. We are working on all the things we have to do to make the resident electives happen. And already we have 2 volunteers, myself and Brian, who will go to Guyana with one of you guys for 4 weeks. We're going to talk about that in your elective block. So exciting stuff. I don't know if anyone's got any questions.
Thank you so much for your enthusiasm. I appreciate the support and just the passion for global health and global surgery.
Yeah, we're going to make this happen.
No questions? I could talk about fistula all day, but
yeah, no, we will have you back. We will have you back. I think we have to, as we're talking about our rounds for next year, Val, we will have a couple of dedicated global health sort of slots that we will ask you to work with us to help Esther, just to keep us focused.
For sure. Happy to.
Wonderful. All right. Well, we'll end off there. Thank you again so much, Esther. Many words of thanks and appreciation in the comments. So thanks so much. Take care, everyone. Have a great day.
Thank you so much, everyone. Take care.